So welcome everyone. Thank you for joining us tonight for our Asia Pacific community event. Let's combat stigma, how changing our language can help. So by joining this meeting, you have agreed that ViiV Healthcare is recording this event. Please do not take any video, audio recording and screenshots. And we have the responsibility to report any adverse events that are raised during the session. Next slide. Welcome once again, and thank you for joining us for this amazing webinar. We are very delighted to have our faculty tonight. Let me introduce myself. I'm Tafen Wang, Patient Affairs Manager at ViiV Healthcare. ViiV Healthcare is a 100% company dedicated to HIV. We aim to end the epidemic and, of course, no leaving any patients behind, any people with HIV behind. Tonight, let me take you through some of the housekeeping matters. So please, this event is being recorded, and please reassure that actually all other attendees, the committee attendees, will be anonymous. Our responsibility is to report any adverse events that are raised during this meeting. Please do not share any information related to your health conditions with us during this event. We are having live interpretations in Japanese, Korean, and Mandarin. Please select your own channel in the interpretation channel. For those who are listening to us in English, please select English, please. So a very warm welcome to everyone. Tonight, it's about language and how we can change our language to help combating stigma. The agenda for let me go through the disclosure of our panelists. Our agenda tonight, we'll have a 20-minute lectures where we'll hear perspective from the community and as well from the healthcare providers on how to start to become free of stigma. Then we'll have a panel discussion where we'll hear our regional experts discussing their reflections on key themes, and they will share experience of stigma in different settings, but as well experience free of stigma. And afterwards, we will try to give you some actionable steps to improve our language and getting to the right language. We are allowing us to have a 15-minute Q&A sessions. So please post all your questions in the chats. We will answer them in that session. So without any further ado, let me introduce you our great panelists and faculty. So please, Gary, would you like to introduce yourself?
Hi, my name is Gary Bruff. I work for Positively UK in London, and I'm the community representative for London's Fast Track Cities Initiative program.
Thank you, Gary. So Dr. Darius.
Good evening. I'm Darius. I've been trained in the Netherlands as an internist and infectious disease specialist, and currently working in Singapore at National University Hospital, where I'm a clinical director of the HIV program there.
Thank you very much for joining us from Singapore, Dr. Darius. We'll have then moving to Japan, right up from Tokyo, Mr. Hiroto, please introduce yourself.
はい、皆さんこんにちは。奥井弘人と言います。東京に住んでいる会社員です。はい、どうぞよろしくお願いします。
Thank you, Mr. Hiroto. Mr. Sejun Park from Seoul, please give us, tell us who you are.
안녕하세요. 반갑습니다. 네, 저는 한국에서 HIV 감염인 단체 러브폰 운영하고 있고 에이즈 상담센터에서 일을 하고 있습니다. 그리고 청소년 성소수자 위기지원센터에서 HIV 자문위원으로 활동하고 있는 박세준입니다. 오늘 이런 뜻깊은 자리에서 함께 이야기를 나눌 수 있게 돼서 너무 큰 영광이고 자리를 준비해 주신 분들께 감사드립니다.
감사합니다, Mr. Park. And last but not least, Fletcher from Taipei.
Thank you. Hello, everyone. My name is Fletcher. I'm based in Taiwan, and I work for an organization called PRA. And it's a great pleasure to join this panel tonight. Thank you.
Thank you, Fletcher. And my co-chair, Neka.
Good evening, everybody, and welcome. It's really great to have you here. I'm Neka Nwokolo, and I'm the Global Lead for Patient Affairs at ViiV Healthcare.
Thank you, everyone. So our objective tonight, and actually those are objectives for all our webinars this year on the theme of changing HIV care in Asia. We would like to build the community knowledge on HIV, get them to have more confidence on their knowledge, and as well have more confidence to speak up in sharing their concern. And from the healthcare provider, we would like to help them to ask the right questions at the end of this meeting and the series of webinars that we have this year. So tonight we are focusing on language. And before we do that, maybe we can try some interactive polls. Please join us in choosing which masks do you think best represent the stigma faced by people living with HIV? Mask A, mask B, mask C, or mask D? So you have 4 different masks on the screen. We have 20 seconds for each of you to give us some indication of which mask you like to. You can also use the chat to explain your choice. That would be very, very interesting for us to. Wow, it's quite very same. We have a quite similar distribution. I think that we have 30% have choose the mask A, and 29% have choose the Chinese opera mask as well, which is very interesting. Thank you very much for your votes. We have another question for all of you, which is more related to our webinar tonight. How much impact do you think language can have on stigma? So is it a lot of impact? Is it some impact? Or is it a little impact? Wow, and 88% already believe that language is important. So I already reached my goal tonight. Everyone agree with me that language changing language can help on reducing stigma. Very well, let's see what our panelists have to say about it. And before going into that, we'd like to understand from your experience, where does it come from? Where does stigmatizing language come from? Do you hear it from your healthcare providers? A, B, from online and social media? C, the general public? Or is it D, family, friends, and colleagues? Or the last option, E, other community groups, whether you are in a sport groups, or you have some different hobbies, or is it faith related, religion related? So which is your choice? A, B, C, D, or E? Please make your vote. I see the general public will take the lead with 36%, but also 1/3 coming from online and social media. I am surprising to see 21% from friends, family, colleagues that are having some stigmatizing language. And I believe this is something we can do, definitely something we can do about it. And from healthcare providers, also we can improve that as well. So without further ado, I would like to invite Neka to the floor to share the next session. Thank you very much.
Hello again, everybody, and welcome. So I'm going to start off with the first session in which Gary Bruff, who I'll introduce shortly, will give the community perspective on experiences of stigma. But before I do that, as we all know, the theme of this meeting is the effect of language on stigma. And WHO has produced, the UNAIDS has produced some really helpful terminology guidance, which is aimed to help us to understand the effect of the use of particular words in perpetuating stigma. And one of these is the use of abbreviations to refer to people living with HIV. So we very often hear people living with HIV referred to as PLHIV, spoken out loud, or written as the abbreviation PLHIV. But this is believed to be dehumanizing. And so the guidance from WHO and other organizations is that the name or identity of a group who is being referred to should be written in full. So for example, people living with HIV should be written in full. Women living with HIV should not be written as WLIV or the equivalent. So this is just something to be aware of. And I really recommend that you look at the UNAIDS terminology guidance if you haven't already seen this. Next slide, please. And so it gives me great pleasure to introduce Gary Brough. Gary is the community representative for the London Fast Track Cities Initiative and the lead for peer learning and partnerships and policy at Positively UK. I'm sure he is well known to many of you, and we look forward to hearing him. Welcome, Gary.
Thanks, Becca, and hello. And I should also start by saying I've been living with HIV myself for over 30 years. I'm working for the last 20 years to provide peer support and training to people living with HIV. And I'll apologize for some abbreviations in these slides as well for that, because actually getting those words into a PowerPoint slide can be a challenge. So in relation to where we're at in London, the reason I'm here is because we were the first city to achieve UNAIDS's 95-95-95 goals in relation to getting people diagnosed, into care, on treatment and undetectable. But I think since then we've moved on, and we're now looking at by 2030 achieving zero transmissions, deaths, and HIV stigma, crucially, which is what we're here to talk about today. And the way that we've been doing this is through Fast Track Cities Initiative in London. We've been pairing up the voluntary sector and the clinical sector to make sure that people living with HIV have access to peer support, can talk to others living with HIV, and to think about that holistic key of well-being rather than just viral suppression, which is really important. And then lastly, in this slide, the Fast Track Cities Initiative are just launching this year 3 separate work streams to address stigma. And I'll talk about that in the next slide. So we start, excuse me, we start in the center with the individual. We know that people living with HIV have challenges in relation to stigma for ourselves. So we may have internalized some of those judgments or comments that we hear from others. And so addressing self-stigma is the work that we're going to be doing first to be able to support people living with HIV to be more confident and to be able to challenge stigma when we encounter it. Next, we think about the places where we may go and access support. And clearly, healthcare is one of the first places. And it's already been seen in your voting that 12% of you felt that you'd heard stigmatizing language in healthcare settings. And that's been borne out in the UK experience as well. So addressing stigma in healthcare, then in government services, in schools, rolling that out to make sure that we have HIV-friendly services has been key. And then the last step of that is addressing stigma in the wider society. We really need to change public perceptions of HIV and bring them up to date, because it's that outdated misinformation that causes problems these days. Next slide. So the 3 areas that I wanted to look at were local, national, and international. And so the Fast Track Cities program for empowerment is that first piece of work on addressing internalized stigma. And what we're doing is we have 6 organizations that are running programs for the next year to be able to train people living with HIV and provide information, education, confidence building, and resilience to be able to live well with HIV and to get over some of those issues that we have around stigma. Particularly, we want to recognize that stigma in relation to HIV doesn't come alone, and that there are intersecting stigmas because of who we are. And so whether that's because we're a member of the LGBT community, whether we're a migrant, whether we're a sex worker or a drug user, all of those particular characteristics are common amongst people living with HIV, and they're also issues and characteristics which are stigmatized in wider society. And so there's that double compounded stigma that needs to be addressed. And so that's one of the main things we try to work on. Also, we'll be training people living with HIV to be ambassadors and to speak publicly about HIV, because we think that personalized approach is what challenges stigma most effectively. So to that end, from that middle point there, at my work at Positively UK for the last 6 years, has been to train people living with HIV to provide peer support and information to their peers. And so we've trained over 800 people. And what we found with that training is that as people build knowledge and confidence, they become more resilient, they become more open, and they become more able to challenge stigma when they encounter it. The third point in that right-hand side bar is the People First Charter. Nneka mentioned the UN AIDS guidance, and the People First Charter was launched last year at the Berlin IAS conference. And it was developed by clinicians, community, and academics to think about how we use language and how we change some of those outdated terminology that we don't need and which continues to challenge us in terms of stigma. And so it provides good, clear guidance and examples. And so I recommend it's worth having a look to the People First Charter to be able to see some of those examples. Next slide. One of the key areas, and the last point I want to make, is in relation to language, but also then in relation to the information that's needed. And the fact that people living with HIV who are on effective treatment with an undetectable viral load, that we can't pass on HIV, is a really, really key message. And that U equals U, undetectable equals untransmittable message, is one of the key things that needs to be got across. In the UK, the British HIV Association has been very, very forceful in recommending that not only that this is the truth, but that consultants, nurses, all of the healthcare providers have those conversations with people living with HIV when they access care. If we go to the last slide, what you'll see is a ViiV study that was done, that was a global study. And you can see the range and the very wide range of levels of communication between healthcare providers and people living with HIV around that U equals U message. The average is there at 67%, which was the total across the board. But the average in Asian countries was only 51%, and it went down to as low as 38% in South Korea. And so I think it's a real key point that when we're talking about stigma, when we're talking about providing information to challenge stigma, that information needs to come from the community, but it also needs to come from the medics, from the healthcare teams, and that we need to be able to provide both a top-down and a bottom-up approach to being able to change our language, change the world, and change the experiences of people living with HIV. Thank you. I hope that's a good starting point, and I look forward to the discussion and panel.
Thank you very much, Gary. A lot of food for thought. So in the interests of time, we won't take questions now. We'll take all the questions in the Q&A session. But can people please start to put questions and comments in the chat, because it will be really great to have these as we come to the Q&A session so that we can address them. Next slide, please. So now it's a great pleasure to introduce Dr. Darius, who also introduced himself earlier, and he will be giving the perspective of the healthcare provider. Thanks very much, Dr. Darius.
Thank you very much. So after almost 4 decades of HIV pandemic, fortunately in some countries, people who are newly diagnosed with HIV can expect no stigma from their healthcare providers, and if they do not get it, they can stand up for themselves and demand it. And I think it was great to see one of Gary's slides that your project 100 has trained more than 800 mentors, peer mentors, and I think that's how we make sure that people are empowered. However, in Asia, the situation is somewhat different. A lot of newly diagnosed patients are worried about being stigmatized by healthcare providers. Sometimes not so much by their HIV healthcare providers, but very much so by non-HIV healthcare providers whenever they need incidental care for other conditions or other issues. This fear and this stigma seen in healthcare is often associated and reinforced with societal norms and prevailing negative attitudes in many, or at least some Asian countries, towards people living with HIV and also key affected populations, which is often associated with conservative social values in some of these societies. So when you look at it from the perspective of the healthcare provider, it is a very challenging situation, because you can imagine that a lot of healthcare providers, vast majority of them in a particular setting, are the products of the society. Most of us practice in the countries where we were born, brought up, and trained as doctors, nurses, or physical therapists. So, excuse me. So a lot of doctors find themselves in a situation where they feel conflicted between their own moral values and their upbringing and the populations that they are to serve. So where to start? Next slide, please. I think that one of the most powerful tools, and this is again something that interlaces a bit with what Gary was talking about, one of the most powerful tools, I think, is including peers in provision of healthcare. So what I mean by that is to have people who openly identify themselves as belonging to key affected populations on your team, and to have people living with HIV on your team as members of your team. I think that when we have that kind of situation, then patients who come to our clinic or to whatever healthcare setting really can feel more empowered, and then they can see their peers working as part of the team and feeling comfortable and being open about their status or about belonging to key affected populations. I think that really reassures populations that we are supposed to serve. At the same time, it also, I think, gives a good chance to change attitudes of those healthcare providers who may find it difficult initially because of their value systems. Because usually when you have personal relationships, professional relationships with individuals, I think that's my personal opinion, you are much less likely to discriminate and stigmatize, because you just see the human in front of you and not just a population, a group of people. However, that's not easy in many countries in Asia, particularly in those where belonging to key affected populations, such as people who inject drugs or men who have sex with men, are criminalized. And also in places where there is some degree of criminalization of HIV. Next slide, please. And the problem is really there. There's not a lot of data about stigma among healthcare providers in Asia. Most studies are rather old. This is one from 2017, so 5 years ago, from Laos, which showed that almost 50% of doctors and nurses were reported to have high levels of stigmatizing attitudes towards people living with HIV. There are also some older studies from other places in Asia which basically show similar numbers. Next slide, please. From experience, my own experience and experience of my colleagues, these are just a couple of examples from real life, which I think very clearly show stigma in healthcare towards people living with HIV. So as you can see here, a dentist refusing to treat a patient and using some COVID restrictions, which actually were not even there, to send patients to another healthcare provider. Counter staff in a physiotherapy center who thinks that he or she needs to check with the doctors whether a person living with HIV can be offered physiotherapy there. And a very unfortunate case of someone who lives with HIV who already got a job as a nursing aide in a nursing home, and after that was not allowed to work and was told that people living with HIV are not allowed to work in healthcare. Something that, by the way, is actually not true, even though there are restrictions on people living with HIV working in healthcare in Singapore, but there is no ban on that at all. Next slide, please. I think that what is helpful, and I think what all of us should do, is actually ask ourselves honestly a question: where do I stand? What is my personal opinion on people living with HIV and key affected populations? What are my own moral values, and how do they relate to the population that I'm supposed to serve and treat? And I think that what we overlook is the role of medical school and medical training, because I think that's where we should have been trained to know that no matter what our view of the world, moral values or religion, what have you, we need to show compassion to everybody and treat all our patients the same way. A patient walking in into a consultation room for the first time should not be playing a lottery. Will my doctor have liberal values, conservative values? Will he be homophobic, or will he be not so homophobic? That should not be the case. All of us should be treating all patients the same way. And I think that really needs to be stressed in medical school from the very beginning. And then during the training, as a peer learning from seniors. And I think that in many Asian medical schools, there is a lot of focus on biomedical aspects of being a doctor or a nurse, and less focus on such issues and such important aspects of being a healthcare provider. Next slide, please. What can we do? I have a few kind of tips that I think are useful for most of us. I think that's important to be explicit about our service being inclusive. It's not enough to say, okay, we are a clinic that accepts everybody, welcomes everybody. Of course we do, everybody does in our hospital. I think we really need to be explicit about it to each of our patients. I think we have to acknowledge to every individual patient that there is stigma, and maybe even stigma in our institution or among our colleagues, but there is but we do not accept stigma in our clinic, and that we do everything we can to educate our colleagues if such stigma occurs, and to encourage our patients to report any cases of stigma, even if they are very close to home. I think that's very important to offer help beyond biologic suppression, to help our patients dealing with insurance claims, because some insurance companies just do not reimburse HIV care, to deal with their employers, with their families. It's important to actively inquire about their sexual life or the lack of it, and because our patients deserve to have full life and also romantic and sexual relationships like anybody else, and to actively promote U equals U. And I think that even though these bullet points you see here and these tips are not really about the language, I think that if as a healthcare provider, we go beyond virologic suppression, beyond looking at the CD4 counts, and we discuss all of this and help our patients with all these aspects, I think that they will see themselves that we are free of stigma, or as free as we can be. So in a way, to use a cliche, the actions speak more than words in a certain way. But I think that as soon as we can freely talk about these things and discuss these things, then we have really made major step forward to have less stigma. And my last slide, because I need to be on time, very quickly. So I think putting it all together, I think we need to self-reflect as healthcare providers and be honest with ourselves. And that's a big problem, because I'm sure, we healthcare providers, particularly doctors, we always think that we are great communicators, and we think that we never stigmatize. I don't think you can ever show me a doctor who will say, oh yes, I stigmatize. Oh, I am not a good communicator. It's just the nature of, it's our nature. We want to be a good doctors, but we have to be honest with ourselves. We have to self-reflect. We should be inclusive in our service provision and include key affected populations and people living with HIV in our services. We should not assume that just because we think we don't stigmatize, we should not assume that does not happen. And I think it's also useful to use non-verbal communication, such as posters in our consultation rooms, For instance, there's a poster here on the slide from Australia about pronouns. Also posters that clearly welcome people from key affected populations to our clinics. Of course, we have to be sensitive. We may not want to put posters about HIV outside because our patients may be sometimes worried that they will be identified as people living with HIV in a society that stigmatizes. Okay, so I think that's about it, what I wanted to share with you today. And I hope I think 2 minutes over time.
Thank you very much, Dr. Darius. That was a great talk, and I think really with nice practical messages about how to tackle stigma in healthcare. There is one question actually that's come into the chat, which I'd like to ask you, and that is, how do we in the NGOs help to remind healthcare professionals of their main oath to do no harm? That means each and every person should leave the treatment center in a better condition physically or mentally than when they arrived. Leave their personal opinions at the door. Focus on the public health perspective.
I think that what's important is that there should be really very close collaboration between healthcare providers and NGOs. And this really happens. I've seen it a lot in the Philippines, where I did some work and collaboration. I've seen it in Indonesia and also here local in Singapore. I think that there needs to be someone in the clinic or in the HIV program of the hospital that really reaches out to NGOs and has a collaboration. And what is also helpful, I think, and this is what we are developing in our program, is we are starting with the patient advisory board. So to have patients and also NGO representatives to have regular every 3 months meetings with us to tell us how to provide better care, not so much clinical care, but indeed less stigma, or what language to use, and some things that we may not even realize. So I think there really needs to be close collaboration, but you need someone in the clinic to initiate it and to feel that there is need for it.
Yeah, very helpful, and hopefully lessons that can be shared. So thank you very much for that. And I would now like to hand over to my colleague Tafen, who will obtain some of the reflections from the voices of the community. Thank you very much.
Thank you, Neka. Let's continue our session with the panel discussion and hear from our expert in Asia. So I would like to invite Hiroto, who you heard already introducing himself at the beginning. Hiroto, please, the floor is yours.
はい、ありがとうございます。僕からは HIV と共に生きる自分が日本の東京で経験してきたこと、その経験から考えたことなどをお話ししたいと思います。僕が HIV 感染をして間もない頃、よく言われた言葉があります。それは HIV のことは周りに言わなくていいんだよという言葉です。皆さんの国ではどうでしょうか。僕が住む日本では、このアドバイスは非常に一般的です。特に HIV の医療やケアを提供する人たちがこの言葉をよく使います。僕はこの言葉を変えたいです。隠すのがいけないと言いたいわけではありません。僕たちは HIV ステータスを告げることで排除される可能性がある社会に暮らしています。他人から HIV ステータスの開示を強制されないことは、僕たちにとって大切な鎧になっています。実際に開示をしたことで不利益や傷を被った友人を僕はたくさん知っています。医療、就職、恋愛、結婚、出産、年老いてからの介護、生活や人生のさまざまな場面で伝えたために僕らは弾かれてしまいます。日本では僕たちの行動が犯罪化されているわけでもなく、むしろ差別が禁止されているにもかかわらずです。治療やケアに関わる人たちが言わなくてもいいと声をかけてくれるのは、 僕たちにこんなひどい目に遭ってほしくないというサポーティブな気持ちからだと思います。実際に隠すことで僕らは社会からの排除を避け、一時的な包摂を享受できています。それにもかかわらず、僕が言わなくてもいいんだよという言葉を変えたいのには、3つの理由があります。1つは、スティグマとの戦いの観点からです。スティグマというのは、具体性を欠いた妄想だと考えています。HIV 陽性者に対する社会のスティグマを変えようと思ったら、僕らが生活を営む具体的な姿を可視化することが必要です。同様に、陽性者自身の内面のスティグマを打ち砕くためには、HIV と共に生きる自分の姿を開示して、その自分が受け入れられたという具体的な実感が不可欠だと思います。僕らがクローゼットから外に出ることは、スティグマと戦うために避けては通れないのです。言わなくてもいいという言葉は、戦おうとする僕らの勇気にブレーキをかけます。僕らが沈黙すれば、スティグマはそのまま温存されて、勇気ある一歩はますます踏み出しにくくなります。悪循環です。言わなくてもいいという言葉を変えることは、この悪循環を断ち切ることだと思っています。2つ目の理由は、この言葉が陽性者本人の主体性を奪っていると考えているからです。スティグマとの向き合い方を決めるのは本人です。確かに簡単に決められることではありません。しかし、言わなくてもいいと医療やケアが最初から結論を示すのは、まるで宿題を解こうと子どもがノートを開いた途端に親が横から答えを教えてしまうようなものです。答えの提示は判断のために必要な情報を得ようとする本人の意欲を低下させます。そして言うか言わないかは自分で決められないんだという気持ち、スティグマに対する無力感のようなものを本人に与えているのではないでしょうか。この言葉を変えたい3つ目の理由は、この言葉が僕たちにとって呪いの言葉だからです。言わなくてもいいというのは、仮面をつければあなたは排除されないというメッセージです。しかし裏を返せばこれは、姿をあらわにすればあなたは排除されるというメッセージでもあります。HIV は隠すべき恥ずかしいもの。この裏のメッセージが僕たちの自己スティグマをより強固なものにしてしまっていると思います。感染が分かってすぐの頃、僕がかけられてとても嬉しかった言葉があります。それは、今言わなくてもいいんだよという言葉です。呪いの言葉に今が加わっただけですが、たった一言魔法の言葉が加わっただけで伝わってくるメッセージは全く異なりました。開示のタイミングを決めるのはあなたなんだ。伝えないのも伝えるのも同じようにあなたにとって大切な決定なんだと言われている気がしました。スティグマとの戦いに僕らが一歩を踏み出すためには、皆さんからの一押しが必要です。言葉が呪いになると自覚してくださるだけでも助けになりますし、今言わなくてもいいと言ってくれるだけでも自信が持てます。でももしできるならこう付け加えてくれたら嬉しいです。私個人としては HIV は隠すようなことではないと思っている。もしあなたが自分を開示することでスティグマと戦おうとするなら、私は全力であなたを支持する。もしその中であなたが傷を負うことがあれば、私はあなたと一緒に怒り、戦うと、そう言ってくれたら嬉しいです。どうもありがとうございました。
Thank you so much, Hiroto. It's so inspiring to me. And I also would also congratulate you for being so brave and coming out, and as well giving us this little change in our language, which I think now at the end of this sentence. And also I would say that ViiV and GSK will back you up 100% in your fight against stigma. Moving on to our next speakers from South Korea, Mr. Sejun Park, please, the floor is yours now.
네, 반갑습니다. 네, 우선 한국의 상황에 대해서 말씀을 드리겠습니다. HIV 감염에 대한 차별과 낙인은 의료기관과 직장, 가족, 친구, 그리고 사회 관계망에서 다양하게 발생하고 있는데요. 감염들이 많이 겪는 경우에는 의료기관에서 진료 거부가 많이 있고요. 그 다음에는 직장에서 하면 되죠. 네. 그리고 한국에서 감염내과 주치의는 사실 감염 사실을 유일하게 드러내고 마음 터놓고 얘기할 수 있는 매우 중요한 존재인데, 간혹 주치의분들이 성소수자에 대해서 안 좋게 얘기하고 또 감염인의 인식에 대해서 매우 부정적으로 반대를 하는 경우가 있는데, 이런 경우에 감염인들이 많이 상처를 받게 됩니다. 네, 다음 슬라이드 부탁드립니다. 네, 최근 발표된 제7차 세계 가치조사 보고서에 따르면은 HIV 감염인을 이웃으로 받아들이지 쉽지 않다라는 질문이 있는데, 거기에서 응답자들의 92.9%가 예라고 대답했습니다. 가장 한국이 가장 높은 수치가 나왔는데요. 매우 충격적인 결과였으며, 이러한 인식들은 아마도 그 언론뿐 아니라 공공장소에서 너무나 당연하게 차별과 혐오 발언을 하고 있는 그런 것들의 영향이 크다고 생각이 듭니다. 그리고 안타깝게도 아직 한국에는 그 차별금지법이 없습니다. 차별금지법이 2003년도에 처음 논의가 되었지만은 보수 기독교의 반대로 인해서 아직까지 제정되지 못하고 있습니다. 이런 차별과 낙인을 좀 해소하기 위해서라도 차별금지법이 빨리 제정이 되어야 할 것 같습니다. 네, 다음 슬라이드요. 네, 저희가 연구를 한 배경인데 2017년부터 2020년까지 여기 3년에 걸쳐서 HIV 감염이 인식하고 있는 HIV에 대해서 인식 조사를 했습니다. 에이즈는 이제 의학적으로는 더 이상 사망하지 않고 관리가 가능한 질병인데, 일반인들의 인식은 너무나 부정적이고, 이런 부정적인 인식들은 HIV 감염인들에게 너무나 큰 영향을 끼치고 있습니다. 특히나 그렇기 때문에 HIV 감염인들이 어떻게 인식하고 있는지를 아는 것이 매우 중요하다고 생각이 됐고요. 특히나 그 당시에 저희 쪽에 확인된 바로는 18명의 감염인이 자살하는 그런 사례들이 있어가지고, 왜 감염인들이 많이 이렇게 자살하는지에 대해서 좀 이유를 확인하고 싶어서 연구를 시작하였습니다. 네, 다음 보여주십시오. 네, 다음 슬라이드요. 네, 여러 연구에서 HIV 감염인은 뇌재적 낙인이 높은 것으로 보여지고 있는데요. UNAIDS에서 실시한 낙인 지표 조사를 보더라도 매우 높은 것을 알 수 있습니다. 2017년까지가 UNAIDS 낙인 지표 조사이고 2020년도가 저희가 한 조사인데, 모든 면에서 한국에서의 그런 뇌재적 낙인이 높은 것으로 알 수 있습니다. 특히나 낮은 자존감과 그리고 나를 탓하기가 가장 높은 것으로 알 수 있기 때문에, 이러한 것들로 인해서 많이 감염인들이 우울을 경험하고 심지어는 자살로 이어지기까지 하는 것 같습니다. 네, 다음 슬라이드 보여주십시오. 네, 한국에서는 에이즈와 관련해서 혐오 발언을 할 때 가장 크게 두 가지 이야기가 나옵니다. 첫 번째가 동성애하면 에이즈 걸려 죽는다라는 그런 발언들을 많이 하고 있는데, 이런 것들을 봤을 때 어떤 느낌이 드냐고 물어봤습니다. 근데 그 말을 들으면 화가 나고 속상한 감정이 든다가 가장 많았고, 그 다음이 그 말이 사실일지도 모른다라고 이런 감정이 든다고 합니다. 가능한 한 영향을 받지 않으려고 판단해 본 적이 계셨고, 또 그와 반대로 자살을 충동을 느낄 만큼 힘이 있다라는 대답하신 분들도 좀 많이 나왔습니다. 이렇게 이런 발언을 봤을 때 벗어나려고 하는 느낌과 함께 자살하고 싶을 만큼 힘든 그런 양가 감정이 느껴지는 것 같습니다. 네, 다음 슬라이드 보여주십시오. 네, 한국에서는 그 HIV 감염인들의 진료비를 전액 치육국가에서 지원하고 있습니다. 그러다 보니까는 반동성애 진영에서 HIV 감염인들은 세금 도둑이다라고 이렇게 표현을 하면서 혐오 발언을 일삼고 있습니다. 이 표현을 봤을 때 어떤 느낌이 드니까 가장 화가 난다가 가장 많았고요. 그 다음이 가능한 영향을 받지 않으려고 하는 게 있었고요. 그리고 그 말이 사실일지도 모른다. 이렇게 많이 했었고, 또 이것도 마찬가지로 그 자살 충동을 느낄 만큼 이런 발언을 봤을 때 힘이 든다라는 생각이 든다고 합니다. 네, 다음 슬라이드 부탁드립니다. 네, 저희가 좀 의미 있게 봤던 건 자살과 관련된 부분인데요. 12개월 동안에 자살을 하는 것에 대해서 진지하게 생각해 본 적이 있습니까? 라는 질문에 무려 59.4%가 예라고 대답을 했습니다. 같은 연령대의 그 일반 비감염 집단을 봤을 때 2.5%인 것을 보면은 높은 것을 알 수 있고요. 12개월 동안에 자살을 계획한 적이 있습니까? 라는 질문도 35.8%가 예라고 대답을 했습니다. 그리고 비감염인들은 0.8%였고요. 다음 슬라이드 부탁드립니다. 네, 마지막으로 12개월 동안에 자살을 시도한 적이 있습니까? 라는 질문인데요. 무려 11.8%가 예라고 대답을 했습니다. 그래서 보통 비감염인 일반 인구 집단이 0.3%인 것을 봤을 때 무려 30.3배가 높은 수치가 나왔습니다. 특히나 한국이 자살 OECD 국가에서 1위를 하고 있기 때문에 거기에 39.3배라는 너무나 높은 수치이기 때문에 사실 HIV 감염인들의 정신건강을 좀 회복하기 위해서도 차별이 해소되는 것이 매우 중요하다고 생각됩니다. 네, 다음 보여주시죠. 네네. 알겠습니다. 저희가 그 낙인과 차별을 해소하기 위해서 어떤 것이 좀 개선되어야 될까 고민해봤는데 가장 큰 것이 인식의 변화이고 두 번째가 정부의 정책이 되어야 될 것 같습니다. 마지막으로 아까 말씀드린 것처럼 차별금지법이 제정되면 좋을 것 같습니다. 네, 이상입니다. 고맙습니다.
Very much, Mr. Park, for this very enlightening sharing of your Love for One report on stigma in Korea. I'd like to hand over the floor to Fletcher from Taipei, who will be sharing some stories about HIV stigma from Taiwan. Thank you very much. Fletcher, over to you.
Thank you, Taifan. Thank you for having me. Hi everyone again. I'm Fletcher from PRA Taiwan. So our focus today is about language. And so a lot of our panelists have explored that like language will be affected by stigma and intersectionality of a person. So when we're talking about combating stigma with language, it's not always one strategy fits all. So what I would like to do is to share different approaches to voice our experience combating stigma, share through two story sharing. So the first story is about a woman living with HIV in Taiwan suffering from uterine fibroids. So this happened in 2017. She was treated by a gynecologist in an HIV designated hospital. And by that time, she was already a grandmother and she was undetectable. And she decided to remove her uterus. And her family and husband all support her decision, but the doctor declined. Doctor only asked her to come back to inject painkiller if she was in pain. And the situation had lasted at least for 6 months. And even a young doctor offered to help with the surgery, but the attending doctor refused. So our friends desperately asked why after several refusals, and the attending doctor told her that she would not be able to wake up if she was anesthetized due to HIV. And it was the time that she felt that she needs to find another hospital in different city. So when she found another one hospital and she explained all the things to new doctor, the new doctor told her that HIV had nothing to do with the surgery, and the new doctor completed the hysterectomy for her. And it was less than half a month away from her being told that she wouldn't be able to wake up because of HIV status. And she shared her story with us and said she wouldn't She didn't want to like really complain or report it. She just only hoped other people living with HIV would be treated with dignity and equality. And so what we do is that we help her to submit this story to a journal to show people her lived experience. So in this case, this woman used the power of written language. And coming to the second story, that a man living with HIV with a spinal problem, the story is that he disclosed his status to medical staff when he was admitted to the hospital for the preparation for the operation. And to his surprise, on the next day, his operation was canceled because the hospital refused to perform surgery on an HIV positive patient. At that time, he was really shocked that his disclosure ended up getting himself rejected. And so, but the truth is that his surgeon was actually willing to perform surgery for him, but the director of the surgery department disagreed. And the surgeon even encouraged our friends to complain if he want to make things to be changed. But the reality is that at that moment, our friend not only suffered from continuing the physical pain, but also the risk of facing status disclosure. So what he do is, after he managed to find another new hospital and schedule another operation and recover, we assist him to really file a complaint, and he stood out to speak up for himself during those investigation process by the authority. And eventually, the hospital was fined by the government because of the discriminating activity against HIV patients in last year. And one thing to be noted, the fine was paid to the government, not paid to the people living with HIV. And in this case, he used the power of spoken language. And by sharing these two stories, it's not focusing on how they won, but what capacity they have been equipped to take actions for different level, whether it's written form or speaking out for themselves. And I guess it also shows that this new norm or new language that we want to create in this webinar, it actually requires a lot of bravery and courage, and also the support from one's surrounding. So to sum up, although knowledge serves the basic for right language and right actions, but more importantly, it's not just the knowledge about science, but also the knowledge about where to get psychosocial support and how we, as part of the environment, provide our support based on their intersectionality. So I would like to reiterate that I guess the language can only make impact when it was written and it is spoken and it's heard, like many of us are doing in this webinar. So over back to you, Tayfan.
Thank you very much, Fletcher, and to all of our panelists. I have many things to say, but I will leave the floor to Dr. Darius to give us some reflection after hearing from all three of you. Dr. Darius, over to you.
Thank you very much. It was really fascinating to listen to all of you. And what struck me is actually that I hear a lot from the very beginning of this webinar through all the speakers, really about empowerment of people living with HIV. And of course, it's a very catchy word, and it's one of these words that are easy to throw in, but difficult to achieve. But I heard Mr. Hiroto talking about being told not to talk about his status and feeling relieved about it, and then how people with HIV actually should be able to talk about their status and expect same treatment as anybody else. But that is very difficult, of course, to face when you are on your own. And very often in many cultures that are very conservative cultures, which we see in Asia also, is people with HIV sometimes cannot even count on support from their families because they do not want to disclose their status to their loved ones. So very often they feel that they are on their own. And that's where really I think the NGOs come in, and also healthcare providers. I'm still really so impressed by this Project 100, where I heard that more than 800 mentors, peer mentors, were trained, because this is how we can through training peer mentors, peer coordinators, we can empower them, and they can empower the new patients coming into clinics or accessing service in the future. Same thing when I heard, Mr. Fletcher again about empowerment, helping people stand up for their rights. My last thought is that it is really so sad to hear that so many people in Korea, and I'm sure situation may be similar in other parts of the world or other parts of Asia, actually are thinking about suicide, and that the risk of suicide is so much higher than in general population. Of course, we knew that the risk is higher for people living with HIV, but these numbers, I wrote it down, I'm sorry, 39 times higher to attempt suicide, 44 times higher to high risk to plan suicide are really very, very, very striking. And again, through empowerment, hopefully we can change also that internalized stigma. Thank you very much. Thanks again for sharing, everybody.
Thank you very much, Darius. I think we will skip this actionable step to improve language and move on to the Q&A session. But please, everyone on the call, write on the chat any action you think you could take over after this call and back to your home and to your peers, your colleagues, and to improve health language. Over to you, Neka, for the Q&A session.
Thanks very much to the panelists for these really wonderful talks. And I think that two themes really stand out for me from this. The first is empowerment and the importance of peer support in empowerment, so that people living with HIV feel comfortable to speak to their healthcare providers and to stand up for themselves when they feel that they're not being treated respectfully or as they would wish to be, but also for healthcare providers. I think what Dr. Darius said really resonates with me also as a healthcare provider, to be aware of our biases and to be aware of the fact that we may stigmatize without realizing it. But most importantly, I think the theme is that healthcare providers should treat all their patients, including people living with HIV, as they would wish to be treated themselves. So there are lots of comments and some questions in the chat. So I'm going to start with the first one, and I will, I think, direct it maybe to Gary to start with. How can we better engage the participation and commitment of the government on the aforementioned? And so presumably Gary will talk about this from the point of view of the government where he lives, but I'll then ask the same question of the other panelists. Thank you.
Thanks, Nick. So I know one of these was around addressing stigma, but it was also around inequalities and where there might be, there was a piece in there also about employment questionnaires which asked about HIV status. And I think one of the things to think about is where we have allies in health. And that it's not just HIV, there's discrimination to lots of different conditions. And we have strength in numbers. If we work together as NGOs, as clinicians, but if we also partner with those who provide care for, I don't know, hepatitis C, mental health, there are any number of areas where there is still stigma. And if we can have coalitions to challenge things and to take things up to this level, then that I think is what has the best effect. Certainly, I provided an example in the UK of how we managed to make it illegal to ask people about any health conditions before you offer them a job. And I think one of those things that's achievable only when you have a lot of different people with a lot of different conditions coming together. So strength in numbers, start with your community, but then make allies is my position on that.
Thank you, Gary. And Hiroto, the same question to you. How do you think that we can better engage participation and commitment of the government in reducing stigma?
そうですね。政府の参画っていうことになると、国によって状況が違って、どのようなアクションが一番効果的かっていうことも違うような気がしています。で、 日本の場合は、過去に血液製剤で感染した人たちが裁判を起こしたことが一つ大きなきっかけになって、政府が動いたことがありました。でそのような国も他にあるでしょうし、そうではない国もあると思うんですけれども、そうですね。なのでやはり怒りを持って声を上げるということは一つ必要なんじゃないかと思います。常に紳士的であることも大切ですけれども、この悲しい状況に対する怒りというのを政府にそのままぶつけるということも時には必要なんじゃないかと考えています。
Yes, thank you. That's really helpful and has worked in many other situations. Fletcher, can I come to you with the same question?
Yeah, sure. Thank you. I was thinking maybe also using one of the example from Taiwan that we have like include U equals U evidence into a criminalization law for especially for HIV in last year. So before last year's July, that even you are disclosing to your status to others, or if you are undetectable, if you did not disclose your status to people you are having sex with, then you will still be criminalized. But after July last year, we have amended that even if you are undetectable, even you don't disclose to your partner, sex partner, or your wife, then you don't have to be criminalized. So what we can achieve that is that through policy briefing and through case study, and also do research on the data. And apart from all of this, I think when we're hearing these words like data, research, and policy, we have to be aware that it's a long way. So I think another keyword for that is persistence. You have to be persistent about what you're going to do, and just keep it in mind that you have to keep that in mind that you are doing the right things. Yeah, thank you.
Thank you, very wise words. And Mr. Park, I have the same question for you. How can we influence governments to reduce stigma? Thank you.
네, 우선 한국에서는 사실 그 정부의 가장 큰 문제가 적극적으로 좀 나서지 않고 있다는 것이 가장 큰 문제입니다. 지금 한국에서 HIV 관련해서 가장 큰 이슈는 대만과 마찬가지로 감염인들이 누군가 콘돔 사용하지 않고 성관계를 하게 되면은 그 행위 자체만으로 처벌을 받게 되어 있어요. 지금 그 조항을 지금 없애기 위해서 지금 노력을 하고 있는데 좀 쉽진 않은 상황입니다. 그리고 또 하나는 감염인들이 지금 여러 가지 차별과 그런 낙인, 혐오 그런 데 너무 노출되고 그런 일들이 많이 일어나더라도 감염인들이 구제받을 수 있는 방법이 없습니다. 그래서 감염인들에게 장애인으로서 등급을 인정을 해가지고 장애 등급을 받으면 장애인 차별금지법을 통해서 그 사람들이 그렇게 하지 못하도록 막기 위해서 HIV 감염인들에게 장애 인정을 할 수 있도록 지금 하는 노력들을 하고 있는데요. 처음에 말씀드린 것처럼 정부에서 지금 너무 소극적으로 지금 HIV 정책을 펴고 있어서 좀 여러 가지 혐오 뉴스라든지 아니면 정치인이나 뭐 그런 좀 유명한 사람들이 그 혐오 발언을 했을 때 정부에서 나서서 좀 그런 것들 아니다라고 발표를 해줘야 되는데 그렇지 않고 그냥 넘어가다 보니까는 사실 그런 것들이 더 확산되고 그런 것이 좀 있는 것 같습니다. 그래서 예, 말씀드린 그 정도로 말씀드리겠습니다.
Thank you very much. And finally, Dr. Darius, do you have anything to add to this? Thank you.
Yes, it's interesting because I can see a whole spectrum of how to engage government from a very Western perspective, where okay, here are our rights, we are coming to get them, to situation where in Asia and in some countries it is not that easy. You cannot just demand your rights as a group of people so vocally. and need to be more nuanced. But I think what I fully agree with for Asian context is keep engaging government and be persistent. Exactly what Mr. Fletcher said. You know, in public health, in clinical medicine, there is always this lag. First, there is science, and we've seen this with U equals U, right? First, there is science. The scientists have shown us what is the truth. Then there's a lag for clinicians to actually introduce it and to believe it and to introduce it to their patients. Again, we saw that with U equals U. And then there is another lag, laws and legislation. So we need to be patient, but we should not give up. So again, engagement and persistence, exactly what Mr. Fletcher said. That will be my take on it. Thank you.
Thank you. Yes, all very thought-provoking. And I think, yes, experiences are different in different parts of the world. And so this has to be sort of adapted to where people are. I think that we are coming to the end of this session. There are lots of comments and questions in the chat, and we will address these after the meeting. But it's been really great to have you participate with us in this meeting, and I'm going to hand over to Tafen for a summary and close. Thank you.
Thank you, Neka. I think it has been so inspiring for me. I learned so much from all of our speakers tonight. I wanted to have the audience to reflect on themselves and how we can improve and reduce stigma by changing our language. And for that, I would maybe ask two of our experts tonight to give us some key takeaway message. Your colleagues, your acquaintance, your friends, your family could change their language to reduce stigma towards people living with HIV. Please write in the chat. We will collect those information and share back to the audience as well in our on-demand video. So for our last key takeaways, maybe Gary, maybe Mr. Park, you can give us a key message for the audience to take away.
HIV 관련해서 그 낙인과 차별이 가장 큰 문제로 처음 계속 이야기되고 있는데요. 사실 낙인과 차별이 없어지기 위해서는 사실 그런 정부의 정책이 그리고 그런 낙인과 차별 발언을 이렇게 공개적으로 할 수 없도록 하는 것이 가장 큰 필요할 것 같습니다. 그래서 일단 한국에서는 일단 차별금지법 제정이 일단 가장 먼저 좀 필요할 것 같고요. 그리고 그러한 것들로 인해서 그 낙인과 차별과 좀 그것들이 좀 작아지면서 좀 감염인들도 건강하지 좀 정신적으로 좀 건강해지지 않을까라는 생각을 하게 됩니다. 네, 이상입니다.
Thank you very much, Mr. Park. Gary, you are the first one to speak tonight, and I will give you the floor for the last key takeaway message, please.
Thank you, Tafen. I think for me, it is that to go back to that top-down and bottom-up approach. We need to be able to campaign for legislation to remove inequalities, to remove discriminatory practice, but we also need to empower ourselves and each other to be at the center of this process and to be speaking for ourselves. So if we can, as people living with HIV, can develop the confidence to speak out and to talk about injustice, then that's going to be the most powerful voice that we have. And the other thing is to recognize that language is a living, changing thing. And, you know, we talked about AIDS for the first 20 years, and now we talk about living with HIV. And so recognizing that these things change and that we need to respond to that it is really important, that this is an evolving process and that we need to evolve with it. And if you're going to do that, you have to learn, and you have to learn from each other. So that's why I work in peer support. That's why I think people living with HIV, talking to each other, supporting each other, and then passing those messages on and up the food chain is the important way to do that. So that's my my perspective.
Thank you, Gary. And I'll ask for the last slides on the screen. We'll have this last poll, which is the same question I asked at the beginning of this meeting. How much impact do you think language can have on stigma? While you are giving us your votes, I would like to commend all of audience for their active participations. I've seen so many messages going through, and as well a start of the coalition. Please keep on the discussion and continue to collaborate and discuss on how we can combat stigma. Let's see the result for tonight. Have this percentage change. Perfect. That's what I was expecting. I was expecting that 100% of the audience would agree that actually we can reduce stigma by changing our language. And this is something we had so many tips tonight from our amazing faculty. I would like to thank you all for attending tonight. It has been very insightful. Please follow us. This event has been recorded in different languages, and we'll be providing all those recording. Follow us with the hashtag #IChallengeHIVStigma, hashtag language matters, and hashtag changing HIV care in Asia. Thank you very much for joining us tonight. Neka, I give you the last words. Thank you so much.
Thank you very much, Tafen, and thank you very much to all of you. We've learned a lot in this session, and I hope that there are lessons that we can all take away from this in order to carry on with this mission to reduce stigma for people living with HIV. Thank you very much.
Thank you very much. Kamsahamnida. Arigatou gozaimasu. Salamat. Thank you very much, everyone. It has been a pleasure to host you tonight. Thank you very much. Have a good night.